ultrasounds being used was one of the questions answered. So that's kind of the thing. WAGS has really gone on top of this. Anyway.
Also thought the clicker, right? Okay, so I also thought that I had to cut down my talk a bit, so forgive me, we're gonna run through this quickly. No financial disclosures. I'm in the San Francisco Bay Area. We'd love to see you there. That's our staff. We're gonna talk about different procedures and bloodless surgery. Who here believes that you can do bloodless surgery? Just the title itself can be a deterrent, but I see some hands up. That's great. Minimal blood loss. So I've been doing this for probably this technique for the last probably 20 something years, and it can be done. These are not just cases that we chose just randomly. Basically, you can go on YouTube and see thousands of these same videos done by me. So minimal risk of anemia, hematoma, postoperative bleeding, infection, blood transfusions, emergency room visits, hospitalizations, re-expiration for evacuation of hematoma and hemostasis. These two right there are probably the leading causes of litigation. In case of blepharoplasty, you can prevent blindness. In case of brachioplasty, you can prevent compartment syndrome. In case of breast implants, you can prevent capsular contracture. And even I think this is implicated in breast reductions and lift. Nipple loss can be prevented. And this is an interesting thing, but I'm going to go in the video through it. I have my theory about oil cyst and blowout fractures in the bottom. This is also very important, and I believe is the result of bleeding. Dr. Guillermo Blugerman postulated the octopus effect, meaning that there is a central hematoma, and then through the tunnels of liposuction, these fibrotic bands can form, and this could be a nightmare. He's got a nice way to fix it. So patient selection is key. Stop aspirin-like medications 2 weeks before and 2 weeks after. Do not administer any aspirin or heparin-like medications. Use the tumescent anesthesia. And I'm gonna, probably the most important thing is to wait. I wait an hour before I start. So that's probably the most important thing. And when we do,
I'm refuted, and there is absolutely no bleeding. Thank you. Next, notice how.
I want to jump through this. This is a brachioplasty.
And normally, when I see these, cases, there's like all kinds of blood and red, and it looks like almost like a war zone, right? This is truly a new technique. If you would like to learn this technique, we'll be happy to show it to you. But this is pretty incredible.
This special technique.
We're going to do basically the same thing on the other side. So I'm going to deflate the sizer of the test implant by 50. And I'm going to go ahead and deflate it by 100. So this one is actually a 400 implant. This is just motor breast. And see if I can do the same maneuver. Like I said, usually Gabby helps me by pushing this, but it's coming out nice and easy. And so that's the way it's supposed to be, really. And now we're going to re-inflate it back up to 50 and 100. And this implant should go in advanced easy. If it doesn't advance easy, that means that we got a problem, right? And so now I'm going to see if I can get it back at the full inflation. Again, using just one hand there and see if we can bring it out. And the implant comes out nice and easy, completely bloodless, right? And now we're going to go ahead and insert the 400 ml implant. This is a motor glass profile. The valve is down. And you do what you do with the camera panel. Sometimes you got to put your hand over here just to make sure that that implant doesn't go on the other side. And another thing that I want to mention is that I don't go from this intergluteal superior incision all the way. Because, look, if I wanted to go all the way to the lateral compartment, look what's going to happen. I can pretty much almost pierce that in the same direction. See, I'm about to pierce the superficial gluteal fascia, and I believe that's how fat herniates into the lateral compartments. And
cases under ultrasound with zero mortality. Dr. Gabriel and Dr. Patino also published about 4,000 cases under ultrasound with zero mortality. And I personally never had any death of any procedure. The way that is done is you inject the bolus usually mostly in the central compartment. There is 7 compartments in the bottom, 3 are lateral, 3 are medial, and then there's a large central compartment. Of course, the medial compartments are the dangerous area. I tend to approach those through the intergluteal incision because even when everybody should be doing ultrasound. When you do ultrasound, it's not a big issue. But so what you do is you put a lump of fat graft in one side, and then you go immediately below it, and then immediately below it. So it's basically just 3 lumps of fat, and then you equalize it. There's different forms of equalization. Some people massage it, some people just disrupt the anatomy with aggressive cannulas. And some doctors, what they do one bottom, and that's probably the better way to do, and then they do the other bottom. When they come back to do the other side, that bump has already come to normalize on itself. So that's probably a better way to do it.
Did you have